kids don't meet typical criteria for depression or anxiety, but they're going into the system and are quickly being labeled depressed, anxious, and ADHD.
But it sounds like they're just reactive. Is that it?
Well, I think we do have to understand what is actually happening. So there is an emotional sensitivity and reactivity that occurs, right?
Uh-huh.
And you'll see the worst of the medical professionals start throwing out the word bipolar disorder.
But reactivity is it's just a teenager thing.
Well, it's a little bit more severe than that. So, I mean, we can't just say
Okay.
it's in a normal behavior, but we do believe it does have to do with both a biological and social interaction.
Mm-hmm.
So maybe it is somebody who's just much more interpersonally sensitive and really derives a lot of self-value from the approval of their peers, and that's always been the case. And maybe they're like more naturally inclined to be artistic or introspective and experience their emotions intensely. And then you combine it with really what's happening in society right now is exposure to that social media. And the opportunities that they have to experience social rejection are just increased exponentially. And that's a very extreme challenge for parents, because if we've decreased face-to-face social interaction and we've dramatically increased this digital world, this virtual world that they're engaging in. We're disconnected from reality more. But the teens, especially these teens, their social world is that phone. That is how they are engaging. So then, not being involved in that social world through that phone, they experience FOMO, the fear of missing out. And then that's the anxiety that they're presenting with, fear of missing out socially. Combine that with the appearance and social related anxieties that they have. They can want to avoid school the next day based on a text interaction or something that occurred like the evening before. And the parents aren't necessarily privy to those experiences, but they've lost such control over that technology that the teen sleeps with the phone. So I was like looking at some data leading up to this. It's like 66% of kids fall asleep with that phone.
Hmm.
And they actually wake up to check it. And so think about what that is doing to sleep disruption, amongst other things, but it's just a reflection of how addictive that device is. So they're being labeled as depression and anxiety and ADHD, and they're going into a system with the worst of our medical professionals, and less than an hour, 45 minutes, sometimes less than 15 minutes. They're given these pseudoscientific labels, and they're prescribed a series of mood and mind altering drugs. An SSRI, potentially a mood stabilizer and a stimulant, almost like the series of uppers and downers to developing brains. And they're interacting with a school environment. So, Riz, I do want to transition into, what you're observing about what has the previous treatment been. How are the school environments, medical doctors responding to these teens? What advice are the parents getting? All of this prior to them ever receiving help at Center for Integrated Behavioral Health. What are you getting? And then I'll share what I'm seeing from the parents' perspective.
Sure. So I mentioned some of the pipelines to people getting into the mental health system, and pipeline feels like the appropriate word because it very much does feel like widgets on a conveyor belt, as opposed to like a deeper contextual understanding of the person themselves. But very often it does start in the school, and in the school there are various ways that a kid can be flagged as having mental health concerns that leads them into that pipeline. One is that many schools have kind of like a safe to say reporting system where a teen can report another teen that they're concerned about. They're concerned about them self-harming, them talking about suicide, that they seem depressed, and they can anonymously make a post, which will lead to that kid being usually meeting with the counselor and having a brief, I'll say, assessment, which I'll describe in a little bit more detail, to try to get a sense of what's going on and to intervene. There's a big piece of that I think is very challenging and puts school professionals in a horrible position, kind of a position where there's no winning here. And I just talked to someone last week who worked at a high school in our local area and was tasked with doing this. And she was given often about 15 minutes to meet with the teen. You're meeting with them at one particular point in time, meaning that your point of contact is just a teen, often at their most dysregulated state, without any other context. You don't often know what's been going on in their life over the past weeks to months. There's very little to no parent involvement in that evaluation, so you don't have that perspective from the outside on what's been happening. And very often, what it ends up being is checklists, kind of symptoms that are looked through to see, is this going to be a problem where they're going to refer and recommend what's referred to as a higher level of care, which I've come to not like as a term. But what those evaluations typically look like is a semi-structured or structured kind of interview, not very conversational often. And you go through kind of a checklist of different things. And these might be things people might be familiar with for suicidality. Is there a plan? Is there an intent? Is there thoughts? Is there accessibility? Based on those responses, however they're given at the time, typically, if anything is flagged, and it's usually quite sensitive, because there's more, it's fear-driven. If we're going to be honest, it's more fear-driven of we don't want anything bad to happen. We want to make sure the kid's okay. These things are, it is sensible, the place it's coming from. But the evaluation is so brief, so non-contextual that it's going to be near impossible to have a clear image of what's going on. So when there is anything flagged, which happens a lot, parents are usually called then and told that they need to take their teen to the emergency room to be psychiatrically evaluated for what their teen is reporting on the questionnaires or saying. Can't return to the school until an evaluation is done and a professional says that they're safe to return back to school. In the worst cases, parents will be threatened with children and youth being called if they don't follow through on doing what is being suggested to seek an evaluation. So parents will typically then bring their teen to the emergency room, and now we run into a little bit of stage 2 of the mess that we're in. We move from a counselor who is being put in a position to evaluate very briefly, and by the way, this is not their training typically either. When someone becomes a school counselor, it does not make them an expert in psychotherapy, in that kind of assessment and intervention. They are often more trained in school counseling, so more possibly adjustment type things, academic things, helping with learning differences and learning in the classroom. Like that's their cup of tea. So they're being put in this position to really assess and provide recommendations that are outside the scope of their expertise, which is not fair. It's not fair to them either. We go to the emergency room, and now we put a whole new class of professionals in this position that is outside their scope of expertise to make an assessment and make more recommendations. So we're talking emergency room staff, might be a psychiatrist, might be an other medically trained personnel. And they are given that assessment that you talked about, Roger. Could be 45 minutes, could be an hour. I've heard it be as little as 15 minutes. I've also heard it be something where the parents aren't really included in that evaluation. They're not asked a whole lot of questions. They're not told what's going on very often. So I'll speak some to what I hear from where we are in the Lehigh Valley. And I, like you, am going to assume and extrapolate that this is probably not the only place in the country this is happening, although you hope there are places that are doing it more ethically. But brief evaluations, again, we're talking spot evaluations. This is one point in time. They know nothing about this kid's history and context. There's no way you get that information in an hour even of one meeting. Very often, other treatment providers are not contacted. It's rare that I don't think I've ever been contacted by emergency room personnel, even if I've been meeting with a kid for a year. I often have to be the one to reach out when I hear from the parents to try to have some coordination of care. But I think that happens a minority of the time. Often there is no inclusion of anyone else involved in kind of a treatment team collaborative way. It's a decision made in the emergency room. So you take that point of time evaluation And the diagnoses are given very freely and very readily, often just from interview. I've seen bipolar disorder diagnosed in 15 minutes of a meeting, one point in time, which I think is criminal. There's no way to diagnose a chronic condition, let alone for pediatric, in a 15-minute interview that the parents weren't even involved with.
And to jump in there, there really isn't a pediatric bipolar disorder. Like, even if we wanted to go to the pseudoscientific nature of a DSM, they don't list it as that. When manic depressive illness, bipolar 1 disorder, has emerged traditionally, it's in much later adolescence. And, a lot of the times it's a misunderstood drug reaction. So just to get an idea how unethical and how unscientific this entire process is, because the fear conditioning that exists here and the coercion is these medical professionals, these psychiatrists, these psychiatric nurses are communicating their parents that their kid has a serious mental illness. So outside any contextual variables, they don't even gather history. It's like they don't even care. Like, why are you feeling the way you're feeling doesn't even matter anymore to these psychiatrists. Like, what happened that led up to this crisis event is inconsequential to them. It's a checklist of symptoms, and then they're trying to determine if this is depression or anxiety or ADHD or bipolar disorder, as if they're completely clueless to the fact that that fucking book has no scientific validity, and they're making things up as they go along. That's why I've lost complete faith in the psychiatric profession, because how can you be so ignorant? How can you be so limited, right? And unfortunately, that's exactly what we're experiencing. So then the parents come out of these environments and they assume that there's, these doctors wear the white coats and some of them wear the stethoscope. I don't know if they ever used a stethoscope, but they have the veneer of a scientist, because that's what the white coat traditionally has meant, that there's science involved. There's no evaluation in that manner. And these parents are concerned, and they'll say, well, I had this great aunt on my mom's side who had bipolar disorder. And then there's the miscommunication of genetics, right? And so now there's this more fear provocation. My dysregulated teen, regardless of the cause, has this genetic inborn brain illness that's been passed down from our ancestors. And it's unbelievable how they can go outside the bounds of ethics to be able to start communicating their propaganda. And that's what it comes down to, is propaganda. So now you're right into this system where the teen is being spoken to as if they're ill. The parents are told that their kid is ill. And now they have a crisis event where they have to now accept the treatment.
And you're in a hospital setting where generally injured or broken people are going. So there's that association as well.
I mean, I've had teenagers, threaten suicide to control their parents, to be able to be on the phone in a particular night so they can talk to their boyfriend, and then go into a hospital, take it all the way, and leave on 3 psychiatric drugs when that wasn't even a legitimate threat. And that's the other thing we're going to have to get to in this podcast, is kids have learned to threaten suicide as a weapon. And it's almost like sacrilege to say this out loud. Oh my God, what if someone says they're suicidal, well, then they're suicidal, right? Because that's the fear we have as professionals. God forbid you invalidate that response. But that's the shift, and that's the change that I've seen over the course of my career. The difference between a depressed kid who's literally contemplating their life versus the one that's using it as a weapon, both on social media and to their parents, in order to get the things that they want. And that's the legitimate challenge that we're saying. So I'm going to take it back to you, Riz, because you did a really nice job of communicating step by step what is happening in the mental health system.
Yeah, and to speak to that point of suicide, it's obviously, I think the sensitivity is to teen suicide does occur and is a serious thing. But it's saying that every situation where anything related to suicide or self-harm is brought up is that's the misconception. And if we treat everything as that, whenever there's any suicidal statement made, self-harm statement made, etc., even gesture actions, without taking the time to understand why that is happening, then we are going to make the problem worse. We're going to be using the same hammer on everything, and it's going to be the wrong tool. And that hammer is not even maybe the best analogy, because often what's used is the sledgehammer when you're trying to remodel and hang up a painting. Probably not the best thing that you want to be doing. So if we take it a step further for what the interventions typically look like, so we're at the emergency room. A diagnosis has now been given. In my opinion, the way it's been given, the amount of time speaks to a level of arrogance, of this confidence in saying this is what's occurring with your teen, the one you've known for 15 years of your life, their entire life. I'm going to tell you this is bipolar disorder after meeting with them for this small window of time, or major depressive disorder, whatever it is. And then typically the referrals are a inpatient setting, an inpatient hospitalization, a partial hospitalization, or a residential treatment. And if it's suicidality and self-harm, I'd say those are the most common things, because there's this conception that this teen is so ill that they are not safe to go home. They need to be under a 24/7 kind of watch, where professionals can be around them to make sure that nothing bad occurs. Again, fear-driven. And they're so ill that they're going to need what you were talking about, which is an average of, I'd say, at least 2, if not 3 or 4 different things that they need to start.
As a reminder, these drugs that they're taking, they're experimental, number one, because they have never been studied in combination. They're often approved for adults and then off-label prescribed to teens. It's like these mad chemists who are adding this drug, increasing it. All of these which have a myriad of significant side effects that affect mood and presentation. And when you're talking about a developing adolescence, we know they're even more vulnerable to the problematic adverse reactions of psychiatric drugs. So what we're seeing in clinical practice is like increased agitation and mood problems, sleep problems, more outbursts, and they're being brought back to the psychiatrist, who is increasing dosages, stopping abruptly one drug, adding another. It's basically this cocktail of these drugs under the disguise that they're legitimate scientifically. They've been established. Even a basic SSRI is completely miscommunicated to the families. Never, and when I say never, I mean I can't identify one time where I asked a parent if they were provided full informed consent, where the range of potential adverse consequences for these drugs were communicated to them in a cost-benefit way, and they could make an informed decision. Maybe 10% are aware there's a black box warning for an SSRI. That's probably at best 10%. And so they completely misunderstand the next subsequent months after the hospitalization and after this psychiatric treatment, because in more cases than not, the situation worsens. It certainly doesn't get better, because you're never actually dealing with what the problem is to begin with. And as it worsens, it's getting then misunderstood as a worsening mental illness and not the drug reactions themselves, which generally adds in more severe diagnoses, right? Maybe it starts with depression, anxiety, but then it's upped to like a bipolar disorder or something more serious. And by the time they get to us and they're referred to the program, it's almost like the local community throws their hands up in the air. And we're almost like a last resort. You should try them. And then we get the bad reputation, in particular me, when I start talking about the drugs as being the issue.